Pain. Who are you going to encounter in the healthcare field that has pain? All right. Who's working ER, emergency department? Is that something you want to work in? Anybody? Yeah. No, I thought about it. No. Okay. Well, obviously you're going to encounter pain there. How about OB? My OB nurse says. You're going to have moms in pain? Okay. Pediatrics, gonna have kids in pain. Okay. Clinics. Okay. Pain, right? You're all gonna encounter pain. All right, so pain is the most common reason people seek medical care. Okay. Number one reason why patients take medications, pain medication. Right? So you're gonna be giving a lot of pain medication. You're gonna be assessing patients' pain. You're gonna be doing interventions for pain. Okay? What do you know about pain? When you think of alterations in comfort or pain, what comes to mind? What have you done for clients in pain? Yeah, pain is what they say it is. And how do they say it? On pain scale, right? You have to use a pain scale. Okay? So whatever the patient says it is, and whatever they say it exists, right? Okay. Technically, we could say it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage. The best pain report or a pain assessment is whatever the patient says it is, a self-report. If they can tell you a number or on a scale, that is going to be your best report. Okay. It needs to be assessed frequently. How often are you assessing pain? Clinical. Maybe every hour if it's severe. Okay. What else do you do in it? After you give a pain medication, before and after, good. Okay, what else? That's one time you have pain? As your focus assessment, right? So at least every 4 hours, you should be assessing it, if not more frequently, the patient has extreme pain. Okay. Now, the best is subjective, right? It's best if the patient can tell you what the pain feels like, but other times when maybe they can't self-report, then you might have to look at objective data. What would be some objective data you could look at?
Grimacing,
Okay, their facial expression.
clutching a part of the body,
What's that?
clutching a part of the body.
Gurney. They possibly have some changes in vital signs. What could happen?
Elevated blood pressure.
Increased blood pressure, increased heart rate, increased respiration rate. Does that mean that I see that the patient has pain? No, not necessarily. Right? Okay. It may show it, it may not. Okay, you could have a pain, you could have a patient who's just very still. Right? Doesn't say anything. Best report is going to be if you can do a pain scale. But you can gather some other information about the patient. Okay. The book also talks about pain being treated inadequately in almost all healthcare settings. We are not treating our clients' pain. Why is that? As a nurse, why are you not treating the client's pain? Maybe it's not being discussed. Okay, so they need a new regimen. What they've got going on is not working for them. Yeah, what else?
Personal biases.
Okay, so look at the cause, maybe more, okay. Yeah.
Could
Not believing the patient,
could be chronic pain.
could be chronic pain, right? So we're not treating it well enough. What was that patient who's like, I don't need pain medication. I'm strong, I don't need it. Not educated, right? Okay. So you might, I don't want to get addicted. I don't want to take that pain medication, I'll get addicted. I've heard patients say that. Okay. So we need to think about all those factors when you're treating a patient who has pain. Okay. Tell me about acute pain. If you got in. What else? You think about acute pain, short-lived, comes on quick. Oh, what happened? Does it have a purpose? Does it have a biological purpose? If there's a stove top that's on, I'm cooking and I put my hands on it,
Just, ouch.
ouch, should my body tell me to do?
Take it away.
You know, right? Biological purpose, right? If I have a surgery, am I gonna have some pain there?
Mhm.
Yes. Okay, so acute pain, there's biological purpose, there might be some tissue damage, there might be some inflammation, it's short-lived, right? Okay. What can happen if we don't treat the acute pain? It can develop chronic pain, okay? So who are you gonna see that has acute pain? Think about the kind of clients you might encounter, right? They come in with what? Toxic trauma, yeah, they have a trauma, fractures, post-surgery. Who else has acute pain? Gallbladder attack, chest pain, brains, right? Then you've had trauma, kind of surgery. Now, there be some, we talked about this, but there might be some behavioral signs also, right? We talked about when you're in pain, right? Might be restless. Heart rate goes up. What about chronic pain, or sometimes known as persistent pain? How does that differ than acute pain? It lasts longer, right? 3 months or longer. Patient has persistent pain. Does it serve a biological purpose? Oh, no. What kind of chronic pain might patients have?
Back pain.
Back pain is a big one. Arthritis, yeah, good.
Chronic migraines.
Migraine, yep. Osteoarthritis, rheumatoid arthritis. Right, a lot of those work accidents, right, back pain, okay, has more gradual onset. Whereas acute pain has more of a abrupt onset. There's a nice chart box on page 95 in your book. Right, it kind of talks about the characteristics of acute versus chronic. Okay, acute, like we said, has a short duration. Usually has a well-defined cause, right? It's caused by a broken fracture. Okay. Decreases with healing, right? When we have a patient who has acute pain, right? They come in, they have a fracture, we give a pain medication, and then over time, what should happen to their pain? It should go down, it should decrease, right? It should, as they heal, it should get better. Does that happen in chronic pain?
No.
No, that's more long term. Okay. Chronic pain then, longer than 3 months. You should be in gradual and persistent. Serves no useful purpose. And it can also be accompanied by multiple quality of life and functional adverse effects. Okay? What would those be? Patient has chronic pain. How can it affect their life?
Mobility issues.
Mobility, depression, financial, they can't work, right? Financial, depression, hopeless, right? Can change their whole maybe lifestyle, their family life. All right, good. How about cancer pain? What would cause a patient to have pain who has cancer?
Tumors.
Okay, could be tumor growth. Yep, good.
Lesions.
Okay.
Lesions.
Lesions, yep. Some of the medications, cancer causes pain. So how do we treat these clients who have chronic or who have cancer pain? Yeah, right? They're gonna do opioids, usually around the clock, right? To keep them comfortable. Again, most cancer pain is persistent. All right, what about procedural pain? Nothing.
Surgery.
Surgery, right? Any kind of procedure. So going to surgery, and having a procedure done, their expected pain with it.
Yes.
It's a medical procedure, you know, you're gonna probably expect some, acute pain. Okay. Pediatric, anybody want to work in pediatrics? Yes, okay, so if you have a child who's gonna have some type of procedure, like let's say we're just gonna do an IV start on a client, on a child. Should we do that in the patient's room? Think about children versus an adult, right? Usually start an IV in a child's, in a patient's room, right? What about a child? They're in the hospital.
They're
They need a
scared.
procedure done, you're gonna do an IV. Do you think you should do it in their room?
No,
Why?
they could
No,
they could expect,
They're safe place.
yeah,
it's the same place.
they could expect more procedures to be done and hurt.
Been to any PEDS units? Right, you might see that they have a procedure room, right? They'll wheel that client down, do that procedure in that room. So they don't associate their room, their safe place, right, as causing pain. Okay, usually adults, we don't usually do that, right? We're like, just give me your arm, we're gonna start right here. And I worked peds for a long time, it was always a procedure room, right? We didn't want to make sure they were safe there. All right, what's nociceptive pain? Have you heard that term before? Tissue damage, it's potential tissue damage, actual potential tissue damage. It's expected, right? It's that expected kind of pain, sensation, transmission that you would expect. Okay? Pain becomes a conscious experience. Normal pain processing. And if you look on page 96, there's a nice little chart there that talks about the physiological sources of nociceptive and neuropathic pain. So when we talk about nociceptive pain, we can also have somatic and visceral. What is the difference between somatic pain versus visceral pain? Yeah, that's your tissue, skin, the tissue. Visceral is more of the organs, kind of the deeper linings of the body cavity. So your somatic is more of the skin, your muscles, joints. Visceral is more like abdominal cavity and intestine. Okay, and I'll give you a little bit different types of pain. Visceral is more like your deep and cramping, whereas nociceptive might be more of your dull aching. So that's that normal pain processing. What about neuropathic pain? Have you heard of that term before, neuropathic? It's the nerves. Who gets neuropathic pain?
Diabetics.
You know about diabetic pain, right? Over time, they aren't treating their diabetes. Right, can develop through neuropathic pain. Okay, so that is abnormal pain processing. So we have some type of damage or dysfunction of the peripheral nervous system, central nervous system. Okay, and what kind of pain sensation might patients with neuropathic pain feel?
Numbness.
Yeah, there's some numbness, tingling, pins and needles. Right, you ever sat on your foot too long and fell asleep, right? Pins and needles. Okay, that would be more of your neuropathic pain. Harder to treat. Okay. Usually isn't effective if we use our traditional opioids for neuropathic pain. All right, so a lot of variety of different types of pain a patient can have. Do you think it's important to kind of know what kind it is? How to treat it based on what it is, what's happening, right? Chronic versus acute versus neuropathic. We're going to treat that differently. All right. So assessing the pain, right? Assessing the pain is very important. I'm going to skip this. We're going to come back to this one. But I want to talk about assessing the pain, okay? You guys know how to do a pain assessment. Have you done a pain assessment on your client? Yes. Okay. So what are some things that you ask your client? When you do your pain assessment, what do you ask them?
What does it feel like?
Yeah. Are you having pain? Right? And then on a scale, okay, how do you know what scale to use? Okay, adult or child, what else? Is it C? What else?
Developmental.
Developmental, cognitive level, that's all gonna be deciphered on how we're asking that time, what scale we're using. Okay, are you having pain? Okay, you're gonna use a scale. What else are you gonna ask?
What does it feel like?
What does it feel like? Describe the pain, where is it? Okay, where's the location? What makes it better, what makes it worse? Right? How long does it last? When did it start? Let me put you, what do you do to help with your pain? What helps it? What makes it better? Is it medication? Transferring, okay, good, what else?
What level of pain do you tolerate?
What range of levels do you tolerate? We're all gonna be different there, aren't we? Okay, what else? Okay, what medication your treatment have been using in the past that work for you? All right, the location we talked about, right, where is it? Okay. The different types of pain, right, what if it's localized, what does that mean?
Doesn't spread.
If you're kind of radiating pain, what does that mean?
Yes. Spreads.
Oh, very much of radiating pain, okay? Intensity. Right, so rate that pain. Okay, describe that pain. What might be some words that the client may use to describe their pain?
Stabbing.
Sharp, stabbing, achy,
Burning.
burning, dull, right? Document that, right? What does the patient say? Okay. Onset, we talked about, right? When did it start? Is it all the time? Is it intermittent? Does it come and go? What makes it better? What makes it worse? What about any effects on quality of life or function? What might you ask there?
How does it affect?
Are you able to do normal activities? Right? Are you able to sleep? Is it bothering you to come to work or sleep? Right? Good. Acceptable level of pain you talked about, right? Do you think past pain experiences could play a role in pain assessment?
Yes.
Why? What was a really bad experience last time you had pain and it wasn't treated? Do you think a patient would have
Anxiety.
anxiety or a bad experience there? Absolutely. Yep, good. Okay. What about cultural and beliefs? Does that have anything to do with pain? Yeah, why? Give me an example.
And so, yeah, I was just gonna say, yeah, they believe that if they're in pain, it's still pain. They just need to, they don't need medication.
Okay, so they might be very stoic. Okay. What else? Are there other cultural beliefs that they might use other things besides?
Yes.
Maybe oils,
There's some cultures that drink like different teas.
teas, yeah. Is that something that you could bring into their plan of care?
Yes.
Okay, what do you say, be careful with?
Side effects with,
Supplements, side effects, does it interact with anything that you're getting done, right? But should you always ask your client, no matter what diagnosis, is there anything that I can do when I'm caring for you, help with your culture, your beliefs, right? Okay, good. All right, so you're gonna assess that pain. You're gonna do a great full assessment. And you're gonna ask all those questions, yes? Okay, because guess what, when you go to clinical and you forget some of these questions, when you go to chart, guess what happens? You gotta go back in and ask, right? Ever happened?
Mhm.
Any question about, describe it, point to it, where's your location? Okay? All right. So let's look at some of those scales. Right, so we are gonna use a scale. And we might use a variety of scales. How do you know which one to pick? What do you think is the most common? For an adult population?
0 to 10.
Yeah, it's your 10 scale. I feel like we use probably that the most common. Right, under the pain. On a scale of 0 to 10, having the word possible pain, can you give it a number? Okay. Pretty common that we will do for that. Okay. What about the FLAC scale, the CRI scale? What do you think about those?
Infants.
Or for your children, right? So FLAC scale, we're looking at their face, their legs, their activity, their cry, their controllability. Is that just being used for children?
No.
Do you have patients who maybe are nonverbal?
Hmm.
Then you might have to do that scale on, okay? Cry scale, we use that for babies. Right, we're looking at their crying, vital signs, expression. The Wong-Baker faces, and then the revised faces scale. Often used for your pediatric client, usually around 3, right? If they're about 3 years of age, you can use the Wong-Baker face. What do you tell the client when you're using the Wong-Baker face? Point to the face that you feel, right? I'm not looking at the client and then looking at the faces and trying to match them up, right? The client is using that scale, okay? For the FLAC and CRI scale, who's doing the scale?
The nurse.
Right, you are assessing that client, okay? When we're using the Wong-Baker face and big faces revised, we're having that client point to how they feel. Your book, I think this came from the pediatric book. Okay, a variety of other scales, and it has a breakdown of when we're using it. So the CRI scale, right? You can use it for neonates up to 6 months. The FLAC scale, we can use for infants and pre-verbal or non-verbal children. Okay, the FACES scale we can use for 3-year-old and older. Numeric scale, 9 and older, right? The Oucher pain scale, 3 to 12, right? So it gives you an idea for range. Does that mean every 3-year-old is going to be able to use the FACES scale? No, right? So you have to tailor it to your client. Are they able to understand it? Okay. Now, if I use the CRI pain scale on my shift, and then Hannah comes and she uses the FLAC scale on her shift, what do you think? What do we need to do about the scales?
Keep it same.
I need to use that same tool, right? As long as it's explaining that tool to the client, if you can. Okay. Good. All right. And those are some examples of pain scales. There's a few here, the way the Wong-Baker, but a lot of these are located in your book. Okay. All right. What challenges do we have when we're assessing pain? Think about the critically ill who are intubated. Intubated, sedated, are they going to be able to answer questions?
No.
Are there some times when a patient is intubated and able to answer questions? Then how would you communicate with them? Whiteboard. Whiteboard? Okay. Do they write a whiteboard? What else? Okay, eyes blinking. Yes or no, right? Thumbs up, thumbs down. Okay, so that, squeeze my hand. Squeeze my hand, yep. Okay, so there's ways that you can communicate. Okay. Cognitively impaired. Okay. Do you think they're at risk for being treated for pain?
Yes.
If they're not able to verbalize. So again, are there scales that we can use for cognitively impaired?
Yes.
Okay. Is it more of subjective data though, looking at the client, maybe looking at their vital signs, right? Okay. Children, we talked about children, right? Sometimes they're nonverbal. So are they going to be able to answer questions? Older adults. They're also at risk, higher risk for not being treated effectively. Patients who have a history of substance abuse. And then obviously a language barrier. If we have a client who speaks a different language or a provider, we can also have some challenges there. So what would we do for a language barrier?
Interpreter.
A language line and interpreter. Okay. Should we be using the family member whenever we're using as an interpreter?
Mm-mm.
Why should we not use the family?
Because they have opinion.
They might not give you that information accurately or to that patient, right? We don't know what they're telling that patient. Okay, so a language line or interpreter if you're helpful. Okay, What are some challenges when you think about a patient who has an underlying substance abuse? What challenges what you come across? Okay, they might already have an addiction. Hopefully,
Not
why
a,
would that be a challenge?
They're not gonna be effective.
Okay, might not be as effective, good,
if they have past history and are now clean, they might not want
they might not want that, yeah,
any pain medications.
good. Good. One thing the book talked about also. Oh, page 103 talks about adapted hierarchy of pain assessment techniques. Okay. So this might be something to think about when you're caring for a client and maybe they're not able to verbalize pain. Okay. As that nurse, you need to be proactive and do a good assessment and be aware of things that cause pain, right? Anything that would maybe cause tissue damage or inflammation, right? Most likely going to cause that pain. So you need to be aware of things that cause pain, okay? The best thing to do is have the patient self-report, right? That is the best thing we can do. We can try to have that patient self-report, but sometimes that won't always be the case, okay? You can observe their behaviors, right? What types of changes they might have, facial expression changes. Being restless is a big one. They decline to restless, can't get comfortable. That might be a sign that they have some pain. Okay. Talks about seeking a proxy reporter. What do you think that would be? Seeking a proxy reporter who knows the patient well.
Knows their
Family member. Right?
normal behavior.
Yeah. What is their normal behavior? Right? Is that, especially if you have maybe a cognitively impaired child or adult, nonverbal. Ask the parents, ask the caregiver. Is this a normal behavior? Did you notice this in the patient? Okay. And then you can also conduct an analgesic trial. Okay. So what do you think that would be?
Either the pain medication works.
Give them some pain medication. See if those behaviors change, the behaviors get better. Okay. Try to figure out what's causing them. We don't want that kind to be, right? Very undertreated. We want to make sure our patients are treated effectively. All right. Some other things to think about. It used to be that children did not, usually the thought that children didn't have pain, or didn't feel pain, the infants didn't feel pain. Okay. Now it is, if an adult has that pain, children have that pain. Okay. So yes. Neonates, children, they are going to have pain, okay? Then there's myths that they have no memory of pain, okay? Sometimes they say pain can be more chronic, okay? Children can easily become addicted, right? No, that there's no reality there, and the actual addiction is very low, okay? Narcotic administration can easily cause respiratory depression, okay? Children are not at a higher risk than adults. Okay. Actually, respiratory depression is very rare in narcotics or opioids in a controlled setting. Right? In a hospital setting, in a clinic setting, when I'm giving medications, we always think, oh, I can't give an opioid, the patient's going to go into respiratory depression. Okay. I said this before, I've given hundreds and hundreds of milligrams of morphine, and I've never had a patient go into respiratory depression. Does that mean it can't happen? No, but it's not just every time you're going to give it, they're going to go into it. Are we going to assess that? What about out in the community? Do we see clients who go into respiratory depression from opioids? Why is that?
Because
Overdose? Too much? What else?
they're monitoring it themselves.
What might be in a pill that you're taking? You know.
Yeah.
Related to something else, right? Variety of different opioids. So yes, respiratory depression can happen, but it's not every single time. Okay, children, infants do feel pain. Okay, if it's painful for you, painful for that child, okay? We might see a variety of behaviors in children and adults. Okay? Top three, right? Those are behavioral signs that we're often gonna see if someone's in pain. What about the bottom left? Depressed, sad, stoic. Okay. What about that middle one? Kind of in a fetal position. What about that client to the very right? Sitting on their phone, got a smile on their face. I'd say their pain is a 5.
Chronic, could be used to it.
To distract themselves.
Trying to distract themselves, okay? Do you ever walk into a patient's room and they say they have pain, they want pain medication, you're like, they don't have pain. How can they have pain? They're on their phone, they're smiling, they're talking to their husband. What do you think? Do you think we can have some biases when it comes to pain? Okay, what are you gonna do about it?
Not a thing.
You're not gonna do anything about your biases?
Nope.
What's that?
It's based on their. Yes.
Yep, what they report is what they say. Have you heard the term frequent flyers, drug seekers? Are there possibly some people out there that are like that? Yes. Have you ever thought about getting the underlying cause and why they're there? What's causing them to need more medication? Okay, so think about biases. Not everybody's pain is gonna look the same, okay? We still wanna treat it, but we want to treat it safely. Okay, if I have a patient who can barely talk to me, can barely wake up long enough to tell me their pain of a 10 out of 10, what do you think? You think that is safe to give that client
Mm-mm.
medication? Okay, so are you an advocate for your client? You want them to be I won't say pain-free, because sometimes we can't be pain-free, right? But do I have to look at the risks and the benefits
Mhm.
of my client? Yes, that makes sense, right? We don't want to give them pain, not give them pain medication because they're smiling. What if they said, oh, my pain's a 10 out of 10? And they're dancing in their room, okay? What would you do?
Might wanna look into it.
Look into it more? What is that pain scale you're using?
Maybe use a different one.
Different ones, maybe you need to educate them on that scale. Like, 10 means it's the worst pain you've ever had. Okay, so just make sure that you're educating them, they're understanding that scale, okay? And that their self-report can be the best one, okay? So this one talks about biases, right? This comes from the American Nurses Association. Right, so think about this when you're caring for a client who has pain, okay? Do you worry about causing addiction? Do I think that some patients might be trying to work the system? Okay. Do I feel anxious when discussing pain medication with other team members? Do I feel guilty about giving too much or not enough? Do I recognize that the patient says it is what really the patient, do I recognize that pain is whatever the patient who has it says it is, but really feel the patient sometimes is not right? So those are some things to think about. What about if you have a question about that pain medication? That client maybe isn't showing outward signs and you're concerned. Are there steps you can take? Are there other people you can talk to? What do you think? Yeah, who would you talk to? Who would you get involved? Okay, charge nurse. Okay, who else would get involved? Provider. Okay, is it okay to explain to the provider your concerns? Are you the advocate for the client? Okay. Some hospitals have pain specialists, right? They might have pain team, right? That can get involved and kind of find a pain plan for them. All right, let's talk about treatment then, right? We talked a lot about assessing, right? Make sure you use the right scale. Self-report is the best. Okay, what are we gonna do about it when the client reports pain? There is non-pharmacological methods. Okay, and then there's your pharmacological. We'll talk about non-pharmacological a little bit later here, but I want to go into and talk about the different treatment plans. Okay, so multimodal, what does that mean? Two or more meds or two or more interventions, right? Why do you think using more than one med or one intervention will help with pain control? They can work together. Especially if I have two medications. Right, they can work together, what else? What else might be a benefit of using two or more?
Reduce gap pain.
Okay, if you've got pain, good. And if I use two more medications, it also might help, I might have to have less of each medication. Okay, and if I have less of each medication, will the risk of side effects, adverse effects go down? Okay. Make sure that pain is individualized, right? We all have pain that's different. Right, so what works for me is not gonna work for you, right? So we always want to individualize our science. PO, right? PO is the best method, preferred method. It's easiest, really expensive. And if a patient has pain, they're most likely gonna go home on a PO medication. Okay. Around the clock here. Okay, what does around the clock mean? Schedule, right? We're gonna give that pain medication every 4 hours. All through the day, all through the night. Okay, who benefits from that? Cancer patients, okay, cancer patients. After surgery, yeah. Usually that first 24 to 48 hours after surgery, you're gonna have pain. It's anticipated you're gonna have pain. Okay. Benefits of giving around the clock medication, especially the client who had surgery. Breakthrough pain. What do our patients do after surgery? Yeah, they don't lay in bed. They gotta get up, they gotta move, they gotta keep breathing. Okay, if I have pain on board, better cancer care. Okay, what about PRN then? What does that mean? Diabetes. When do we give PRN then? Okay, migraine.
We typically give it after surgery if the, original scheduled medication isn't.
That, we might add that to the around the clock one. That's good. What else do you have PRN medication? What if your patients have PRN three? Right through here? Yeah. Before, sometimes maybe even we'll get a little extra, maybe before they go for a walk, right? If they need to go to therapy. And then we have, PCA. What do you know about PCA? Patient controlled analgesics. Same for sure. Which one? What is the benefit of it? Of PCA? Okay, if a patient's having pain, I can push my button versus if I have come in and ask you, oh, I have pain. That's what I have to do. Go get it. I have to go to my room, I have to prepare it, right? Come in and play very come back. Okay? The patient has control over their pain. Okay, good. Any other benefits?
Hospice patients.
Hospice patients can use that, yeah, good. Who can use the PCA? One patient? Hospice, right? Somebody has to use it. Push the button. When they know they have pain, they can push the button. Nobody else should be pushing the button. While they're fine. Okay, can you look use it? Depends on age.
Yeah.
Sometimes they say 5, sometimes they say 7. But what does that child need to be able to do?
Understand.
Understand, right? If they're having pain, push the button. Who pushes the button? Well, the client, right? Not the child, not the parents. Right, they need to understand. Yes, children can use this. All right, so when we talk about pain medication, the big part of this is our pain groups. We have 3 analgesic groups, non-opioid, opioids, and then we have our adjuvant or our co-analgesics. And it can help along with that. Okay. So what are examples of our non-opioids?
Tylenol.
Tylenol, acetaminophen, and NSAIDs, yeah, those are gonna be your non-opioids. Acetaminophen, NSAIDs, okay? What are your opioids then? Give me examples. Hydrocodone, morphine's a big one, right? Hydromorphone.
Fentanyl.
Those are your opioids. And then what about our adjuvant analgesics? Or these are the ones that we use in addition, co-analgesics. Gabapentins, yeah, so those could be your anticonvulsants, your antidepressants, like SNRIs, local anesthetics, muscle relaxants, right? Those can all be considered part of your additional co-analgesic, right? Do those adjuvant medications, is their main purpose for pain? No, so, right? Their main purpose might be for depression, their main purpose might be for seizures, right? But we can also use those for pain, right? Those off-label uses of a medication. All right. Let's take a break. It is 9:55. Let's come back and, oh, the first group I'll talk about is the non-opioids. Okay, so common ones are gonna be acetaminophen, and then your NSAIDs, like ibuprofen, naproxen, ketorolac, okay? Many formulations, are these over the counter?
Yes.
Yeah. Okay, what kind of pain are we using this for? They're mild to moderate. Okay, so what would be an example of mild to moderate? How would they rate that maybe on a pain scale? 2, 3, 4, right? Then become your mild to moderate, right? Okay, so you're more like 7, 8, 9, 10, okay? Okay. Often can be added with other medications. Okay, so where do we see these other, where do we see acetaminophen and NSAIDs also in? What other complications? We can, your opioid, yeah, what else? What about your over-the-counter meds? Yeah, right, and your cold medications usually have ibuprofen or Tylenol or acetaminophen in it. Okay? So non-opioids. So acetaminophen, it helps with pain. We also may give it for what? Anti-diuretic, right? So for fever, right? Okay. Who can take acetaminophen? Everyone, right? Children can take it, okay? What do we have to worry about with the, with the daily dose of acetaminophen?
Not exceeding the
Not
max.
exceed what?
4,000 for a healthy adult.
Adult, right? Healthy adult, 4,000 milligrams or 4 grams, okay? What would you rate it have to be a little bit less?
Hepatic.
It got your liver, right? You have a liver issues. Okay. We can give it IV, PO, rectal. Careful though, because an overdose, right? An overdose can cause liver toxicity, liver injury. What is the antidote for acetaminophen overdose? Yeah. Good. Okay. Cause liver damage. All right, what about your NSAIDs? So ibuprofen, pretty common over-the-counter medication, right? It's an analgesic, but what else do we use it for? Anti-inflammatory and antipyretic, right? Okay, non-steroidal anti-inflammatory, right? To help with inflammation. Okay, over-the-counter. Children should not take this unless they're 6 months and older. Oral, PO, right? Topical. Do these ibuprofen, naproxen, diclofenac, that's like that, what's it called? Voltaren, yeah, thank you. Okay, so it'd be topical. Okay. Next to ketorolac. You have to be worried about ketorolac. Yes. A wonderful medication. Give it IV. Can only use it for 5 days. No longer than 5 days, but what, it's really hard on what? Kidneys. The kidneys. Yeah, really hard on the kidney. Works wonderful, patients love it. But you gotta make sure you have good kidney function. How do I know I have good kidney function? Output, what else do I check?
BUN.
BUN, creatinine? Okay, good. Pretty common. Okay, what else are side effects of, enzyme, especially ibuprofen? I think ibuprofen every day. Yeah. Okay. Not good for hypertension, right? It can cause some cardiovascular issues too, increased hypertension, okay? So GI bleed, right? So how do you take this medication? What's the way to prevent it? Okay. So take it on an empty stomach, you know, okay, good. What else? So yeah, be careful with your clients. For the GI bleeding, they're at risk for hypertension, cardiovascular risks also. Okay. Otherwise, pretty safe, right? We use them pretty frequently. What about your opioids? Okay, these are probably the more common ones that we're gonna use for moderate to severe pain. So morphine is probably the most common when it comes to your opioid, okay? So our pure opioids, morphine, fentanyl, oxycodone, hydromorphone, hydrocodone. If you haven't already looked in, the Peace book, there's good charts in there about all the different opioid medications. So if you haven't had a chance to look through that, that's a good resource. Okay. So what do you know about safety with giving an opioid? What are some things I have to worry about? Next, we have to watch for respiratory. That's allergies, good. Constipation, yes, constipation can be a side effect of it. So morphine, like I said, is probably the most commonly used. Cancer patients will use morphine. Okay, we can use it IV. Okay. Sub-Q, rectal. Has a slower onset with a longer duration. With any of these, is there a risk for dependence?
Yes.
Is there a risk for tolerance? Tolerance.
You need higher doses.
That take higher doses to have the dream of that. So we gotta watch for sedation, right? We need to watch for constipation. We need to watch our respiratory rate. Okay. Sometimes patients can have nausea and vomiting that goes along with taking an opioid. Sometimes they might have a urinary retention. What do you know about fentanyl?
Fast onset, short duration.
Yes, very fast onset, but a shorter duration. Okay, so those clients that need rapid analgesic, right, we can give that IV. It's gonna work really quick. Okay. It also causes less hemodynamic instability. So if you don't have any changes in your blood pressure, your heart rate. It also doesn't have any metabolized. Doesn't have any metabolites, so it's good for clients who are in end stage renal disease, end stage liver disease, right? It doesn't involve any metabolites, so it's a good medication for those clients who have end stage organ failure. IV, transdermal, right? We do patches. Fentanyl patch, another patient on a fentanyl patch. What do you know about patches? When you're placing a patch on a client.
Gloves.
Assess the skin. What do you avoid?
Hair.
What's that?
Open areas.
Open areas.
Hairy.
If you break down in skin, right? Scarring, right? We want to make sure that hair, right? We want to make sure it sticks. Okay. How long is a fentanyl patch usually placed for?
12 hours?
72. Okay. Sometimes it takes anywhere from 12 to 24 hours before it starts to have its full effect. Okay, so I put a patch on. And 4 hours later, you have pain. Oh, patch must not be working, better take it off. Right, it's gonna take some time. So in the meantime, what am I gonna do?
PRN.
PRN, right, it's PRN for the breakthrough pain, yeah, okay. So 72 hours on. Okay. Obviously, I need opioids, watch for respiratory depression, bradycardia, hypotension, those can all occur. Okay. We have hydromorphone. Okay. Maybe not often, I don't know, do you guys do hydromorphone very often? Maybe your oxycodone, right, you guys heard that one?
I see hydromorphone a lot in the ER.
Where?
In the ER.
ER, okay. So good IV one. Okay. Again, it can be an alternative to morphine, morphine seems to be kind of the mainstay. We've got oxycodone. And we've got hydrocodone. Okay, so they're all gonna be used for moderate to severe pain, okay? They all have a risk for bradycardia, hypertension, respiratory, okay? So if you're giving this patient continuous pain medication, what should you be watching for? What might they be connected to? Pulse ox, right? Checking their oxygenation, checking their respiration, doing, continuing with checks on your client, right? A large amount. What about methadone? Have you heard of methadone? Yeah, what's methadone used for? Yeah, so the patient has an opioid
Addiction.
right? We can give them, methadone. Long. Long time. And then the client can be titrated so that they don't have those withdrawal symptoms when they come off of the, right? They have opioid addiction. Right, why do patients continue to take opioids?
Because of the withdrawal.
When you come off an opioid, what do they feel like? Crap, right? They don't feel good, body, feel good, right? So methadone can be given. It can be given for pain also, but a lot of times you'll see other patients who have a substance abuse disorder. It can be given to help that patient treat their addiction. All right, so those are considered your opioids over a variety of different ones. What is an opioid antagonist? Naloxone. What are we doing? When do we
To
give
treat
naloxone?
Opioid overdose.
Patient takes too much opioid. They now have a respiration rate of 4, right? And they're not responding to you. I'm gonna give them naloxone. In the hospital setting, are you seeing naloxone as one of your orders? PRN is given by an opioid. Okay. I was also told, I don't know if this is true. Has anybody know anybody who's been recently prescribed an opioid analgesic? That they're also sending them home with naloxone. Is that true?
She had hip surgery and
Okay,
she had like Dilaudid and, you know, fentanyl and they said it.
okay,
It's on like patients.
okay. I was not aware of that. That's
Hmm.
part of the protocol now. So they're teaching, the nurses are teaching
I think
you or the.
Yeah, the pharmacist will teach them. Like when I take patients down to the pharmacy to pick up their prescriptions for like post-surgery, they'll go over like.
But what about if I'm in the clinic setting? And I've been prescribed an opioid. Anybody know about that? Is that something they're also doing naloxone?
Yeah, my kid had his wisdom teeth out and he got bited in and they did the same thing. Yeah, he's, I've done a lot.
Okay, so just give you a sub-Q, naloxone, and then teach you to.
No, it's the
Nasal?
nasal one, yeah.
The nasal, okay? that what you guys had to the nasal? Is that what you're saying?
I'm not sure.
Okay,
Yeah, I'm not sure what that is, but.
that's interesting. Okay, so that's the new protocol. Okay. Oh, I thought there were just two. Oh, was that,
Yeah,
5 years.
Well, I'm on,
I
I'm
thought
on
they only did because it was 216. I thought they were like, he's gonna use up. No. I thought it was like he's underage, they're worried about it, but maybe.
All right, so, are we seeing this in the community also?
Yes,
Right?
There's a-
Responders, right?
there's a,
People who are, substance abuse, they'll have, some walks in a home, right? Providers will give them, or, services will give them, so that. All right. So opioids titration, we always want to start low and go slow, right? Lowest amount. And then if it's not working, then we can titrate up. Okay? What about our client who is a hospice, end of life? We're giving them medications for pain control, right? What do you think about that when it comes to titration? Or not?
no,
Or you might be titrating one,
up,
right? Okay. So that might be a little bit different, right? If you're working hospice care where you have a patient end of life, you're gonna keep them comfortable. Okay, you're not worried about their constipation. You're not worried about if they maybe have a slower respiration rate. We want to keep them comfortable, right? But usually if we give a patient an opioid, right, for pain medication for surgery, our titration should be down, right, coming off of that. Okay. Constipation, nausea, vomiting, sedation, respiratory depression. Okay. How do you help a client who has a risk for constipation taking an opioid? Fiber and fluids. Good. Okay. What about nausea and vomiting? Okay. Might need some Zofran. What if I don't have Zofran? Was it premium?
Mm,
No alcohol. Okay.
that is actually very helpful.
Okay. So we maybe have them take it with sedation, respiratory depression, obviously not everybody has lost so at home, okay? But in the clinical setting, hospital setting, you'd be assessing your patient, right? You'd be assessing their respiratory rate, you'd be assessing if they have sedation. All right, good. All right. Adjuvant analgesics are those medications that will be used, again, not as your regular medication for pain, okay? So we have anticonvulsants, okay? So our gabapentinoids, tell me about those. And I know what class that is, or what medications fall within those. Gabapentin, yeah. Yep, and pregabalin, yep, gabapentin and pregabalin. Those are considered anticonvulsants, right? But they can also help to treat pain. And these are often used to treat what type of pain? Neuropathic pain, right? Neuropathic. Pregabalin, gabapentin. It can cause a little bit of sedation, a little bit of dizziness. So making sure that you're keeping clients about that. Some antidepressants, your tricyclic antidepressants. Okay, those are gonna block those, neurotransmitters, norepinephrine, serotonin. Okay. We're gonna block those, and that is gonna help with pain. So examples of tricyclic, amitriptyline is one class of that, so the tricyclic. Also nortriptyline. Okay. They can cause dry mouth, sedation, hypotension, so when you're assessing that, you're teaching your students about, taking that. And then SNRIs. Duloxetine is a big one. Usually used for depression. Duloxetine might be one that you usually use for depression, but can also be used for one. Watch for nausea, sometimes weight gain, conservative, headache. So these can be used in combination, right? With other medications, kind of like I said, co-analgesics. All right, so pharmacological, now let's talk a little bit about non-pharmacological interventions, okay? So these are not obviously using any type of medication, right? And there's a variety of different class or kinds of interventions here. Physical and cognitive behavioral are the ones that we're gonna kind of focus on, okay? Your physical is more of your body, right? So think of things such as acupuncture, walking, heat cold, physical therapy, occupational therapy. Okay? Cognitive behavioral is more of the mind and body. Okay? So decrease your focus on the pain, kind of block the transmitters. So the book talks about breathing, prayer, meditation, guided imagery, distraction. Okay. Aromatherapy. What kind of non-pharmacological interventions have you used for a client? Hot, cold, okay, ice packs, warm packs. You just did the alcohol spot, right? Would that be non-pharm? Okay, what else?
Essential oils,
Histamine,
essential oils.
essential oils, yeah, that's a good one.
Calm environment.
Turn off the lights, low stimuli. Okay. Variety of things you guys do all the time. Some of it is harder. Okay. If a client had severe pain, would this be your first choice? Non-pharmacological. Okay. Would you include that with other things? Okay, right? So again, it's not always pharmacological, but sometimes it's a warm blanket and your positioning. Okay, but there are a variety of different types, right? So you've got yoga, acupuncture, right? Listening to music, and everybody's gonna be a little bit different on what works for them. Okay? What might work for you might not work for the next patient. Okay, so use that in addition to any of your medications that you might do. Okay. There's also local anesthetics. Okay, has anybody ever had to put a lidocaine patch on a client? Yeah, yeah, so pain, right? It's for pain. Not you, babe. Okay, where do you put the patch at?
Pain.
You're having the pain. Okay, and it's on for how many hours? 12 off for 12. So as that nurse, you need to monitor, right, document when it was placed on. When is it taken off? Okay, so lidocaine can help decrease that. A topical local anesthetic, just like it said, right, go on the skin. Okay, has anybody ever heard of Embla cream?
Mhm.
Yeah, okay, so Embla, so it's a lidocaine type of cream, you put it on, usually I use it for kiddos, right? IV starts, okay, so you put it on their hand with the cream, you put a Tegaderm over it, half an hour later, it numbs up that area, so there's less when you do an injection or when you start it. You can use it for adults too, but tend to see it more in the pediatric population. All right, and then there's nerve blocks, right? So that could be an injection of medication into a group of nerves that's causing pain. We might have a patient who maybe had some type of surgery. So a lot of times I think it's what lower extremity surgery. They'll put a nerve block in, right? And it might last them 12, 24 hours. Right? It's gonna wear off. Okay, the your patient's gonna wear off, and then you'll have to try other medications. All right, so PCA we talked about a little bit, right? Self-administering, the patient has to be cognitively and physically able. Who sets up the PCA? Two nurses. What happens if I need to change the dose of the PCA?
2 nurses.
Okay, so make sure that the nurses are the ones who follow the doctor's orders, but you'll be responsible for setting it up. Tell me a basal dose versus a demand dose. So some
Basal.
clients might have a basal. What does that mean?
It's like a continuous,
Yeah.
you're getting it.
So You have a continuous amount, so you might get 1 milligram each hour, right? It's a continuous amount. And then what's the demand dose?
So when you press that button,
Whenever you push the button, that's the dose you're gonna get. Can I get an overdose of medication? If I just keep pushing that button,
No.
I'm gonna get medication each time?
no.
Usually it's set for like every 10 minutes, every 15 minutes, depends on the patient. Okay. But we tell the patient, if you're having pain, push it. Okay, because what happens if we go back and check and we notice our patient pushed it 50 times in an hour? Maybe we need to change that dose, right? And we need to up that a little bit. Okay, or we need medication. They're not gonna overdose, we're not gonna give them too much if they keep pushing the button, because it's set to maybe only give 2 milligrams, like I said, every 30 minutes or whatever it's set. Okay? If a patient has a basal and a demand dose, right? What happens when they start to get a little sleepy, some sedation, the respiration rate starts to maybe go down a little bit? What do you think we probably need to do?
Back that basal off.
Yeah, probably not. Maybe turn it off. That basal dose or kind of back down a little bit, right? They might just be getting too much of that medication. Okay. Clients on a PCA are usually put on, Holta. For monitoring, additional monitoring, we check for heart rate, respiration rate, your O2 stat, right? To make sure that we're not getting that. Like I said, you can do it as young as 5, but again, the patient needs to be able to understand how to use the button on their own, okay? Not having anybody else push the button for them. All right, the last thing I want to talk about is intraspinal medication, okay? So some clients might have an epidural or an intrathecal space medication, okay, to help with pain. Okay. Intrathecal, right, that's going right into the, spinal fluid. Okay. Also known as the subarachnoid space. Okay. Usually morphine, usually it's just a single bolus, so like a one-time injection, help with pain. Like an example of located was like a hysterectomy, right? The client's going for hysterectomy. If we give a one-time dose of medication, that'll help with the pain during the surgery. Epidural then, that's probably one you're more familiar with. Right? You guys had OB, you guys talked about epidurals and OB. Yeah, what do you remember about that? C-section, what's so funny?
I said they're fantastic.
I recommend them to anybody. When a patient gets an epidural, right, we're going to the epidural space, okay? It can be, again, for pain control, right? Or it can be for anesthesia. Okay, so labor is a big one, surgery, chronic pain. Do you remember what you give to that mom or anybody who's getting an epidural before you start the epidural? What's commonly given beforehand? They know they're gonna give, who's that it? Yeah, what do they get? A bolus of fluid, right, because what happens with epidural? They'll drop their blood pressure, right? So a lot of times we know that the patient's gonna get an epidural, they'll get a liter of fluid, a bolus of fluid, keep that blood pressure higher than it was, right? The epidural is still gonna bring that blood pressure down a little bit, but it won't put it higher than much. Okay, so yeah, hypertension is a big side effect, so watching for that. Nausea. Headache, there can be some headache. Can we give that patient too much medication? Okay. What are you assessing for, especially when you have an epidural, right? What are you assessing for?
Feeling,
Really? We don't want to go too high because then what happens?
start not feeling. Yeah.
All right. I have some scenarios I want you guys to work through. Okay, here. I have 4 pain scenarios.